ECG study group, and today is the 95th session of ECG study group presentation, Basic and Beyond. The presenter today is Dr. Abdullah Al Jamil sir, Senior Consultant, Asgar Ali Hospital. Before start of the lecture, I'd like to request Professor Atahar Ali sir to speak about Dr. Abdullah Al Jamil sir, and then we proceed for the lecture. Atahar Ali sir.
Good evening. Dr. Abdullah Al Jamil is very much well known in this forum. He is a regular participant. He is a renowned clinician, academician, cardiologist, interventional cardiologist, as well as electrophysiologist. Very, very popular in this country. And he's also a good presenter. We have already done several presentations of Dr. Abdullah Al Jamil. And I hope everybody will enjoy his presentation. Dr. Abdullah Al Jamil is you are welcome to present your cases. Case-based discussion, Dr. Abdullah Al Jamil.
Thank you, Atahar. Let me share my screen. I am audible to everybody?
Yeah.
Today I'm going to show 4 cases. The case number 1 is a 78 years old gentleman, non-smoker, non-hypertensive, non-diabetic, presented to ER with drowsiness and reduced responsiveness for 3 days. He was brought from Kishoreganj to our hospital. Pulse and BP were non-recordable at the ER. Other comorbidities were COPD and benign enlargement of prostate. This was the ECG recorded at the ER. Nabila, can you please arrange for poll?
Keep the poll for 20 seconds.
কিন্তু কোশ্চিন গুলো কই? হ্যাঁ
সাইডে আছে।
Okay.
What would be the diagnosis? Everybody opted for the number 1, but if anybody want to explain this from the audience?
We encourage our audience to discuss the ECG, as we all are learning from the ECGs that are being shown.
From the audience, please raise your hand.
Sir, can I make a comment?
Yeah, sure.
Sure.
Sir, the majority answered is the answer 1, complete heart block with acute MI inferior. Sir,
What is your opinion?
Sir, so I don't think like that, because it's high grade AV block, and the ST segment that appears to be elevate, the ST segment is a bit confusing, it's for sure.
Yeah.
But the QRS that appears is the escape rhythm that I feel. That's my feeling, sir.
Yes, if it is escape rhythm, then it goes in favor of either junctional block or complete heart block. But if we look at the PR interval,
Jamil,
there are equidistant P waves at the bottom. Yeah, Atahar bhai?
no, these are not the escape rhythm. These are the conducted QRS.
Conducted QRS.
Yeah.
Because every QRS is preceded by the
By P wave.
P block, and QRS are
And-
the LBB morphology. That is conducted QRS with LBB morphology.
Sir.
And PR interval are the fixed. So it is
High
at the
grade.
point of the complete hand. Hafiz bhai.
Yeah.
It's high grade.
I agree, because the PR interval, whenever it is in the first QRS, then second QRS, third QRS, we are seeing this PR interval is solid. There is no suggestion for PR
Prolongation.
dissociation. But if you map, it does, PP intervals are solid and PR relationship is still there. So it is high grade AV block. And there is inferior STA changes, because look at the biphasic nature and then the STA elevation. I would go for acute inferior with the high grade AV block.
But Hafiz bhai, on the that is the in presence of the LBBS, because the QRS, that is the lead one, and the V1 shows the patients had the QRS is the LB morphology. So LB in presence of this LB morphology, whether we
Yes.
can for that is the diagnosis of the inferior MI will be straightforward or
So I mean, question is that lead one looks like left bundle, but you can call it IVCD and still interpret, because it is difficult to see that in the precordial leads, the morphology does not look like left bundle.
true.
So I'm not sure. So we don't have any choice in the answers. So I would tend towards accepting inferior, and it is high grade AV block, so it goes along with that. But if you commit to left bundle, then we are stuck. But I'm little
Sir.
shy of accepting left bundle, but because the precordial leads are really not suggestive. Although I don't have anything in
And-
B5, B6.
Sir,
Though
before
the
5,
QRS are notched in the limb leads, but the duration is not wide. To
Sir, QRS in
Wadud,
lead 1 and AVL is quite wide. It appears wide. And the QRS is
not more
apparent
than
in 4, 5,
2.5
6.
millimeter.
Can I say
Tushar, not-
something?
Sure.
See, I think this is inferior MI with a high grade block, no doubt. But this could be an interventricular conduction defect. It's not really
Yeah.
matching with the LBBB. So, in the setting of clinical context and patients suspecting MI high grade block, it could be interconduction delay. That's all.
And if we count the P waves, there is after every 4 P waves, starting from here to the conducted one QRS complex, it is constant like that. So I put this acute inferior MI with 4:1 AV block.
All right.
So I go for the next. So this was another ECG of this patient. Please give the poll.
Same patient?
Same patient.
Yeah. This ECG much more clears the doubt.
Again, the first one. Okay. Tushar? Anyone?
Only one participant answered the question, although it appears there is Q wave pattern in 3 AVF and 3 and AVF. But if you look close carefully, the picture closely resembles the picture that we find in hyperkalemia, that the T wave in the chest leads and the PR interval and PR relationship is totally variable.
Is there any spike in the V2, lead V2?
There's clearly, there is no
Spike.
relationship between P and the QRS complexes. And question is that this is probably, what is the heart rate? It's a little bit accelerated idioventricular.
Yes.
And then underlying high suspicion for hyperkalemia, isn't it?
The T wave is giving an impression of hyperkalemia.
Yeah.
Can I make comment?
Sure.
Yes. Here is the underlying rhythm is the complete heart block, but the RR interval is the fixed. And I think there are very teeny spikes before the QRS complex suggesting of the presence of the pacemaker. There is the paced rhythm. And this is against the LBBS because lead 1 suggestive of the late bundle branch block. V1 is not typical. And V6 again negative, that should be positive in case of the typical LBB. So inferior lead, there is the lead 2, 3, AVF suggests that is the apical pacing, right ventricular apical pacing, and pacemaker is working in the VVI mode. This is my interpretation. That is the paced rhythm.
So I don't see any pacing spike. Is there any pacing spike?
There are very little spacing spike.
Very tiny spike is
tiny
being
spikes are there.
very tiny spike.
Let's say in V, this
V2
point,
is more clear. I feel V2 is more clear. Yeah.
Yeah. Here, actually, it's a pacing ECG. As the patient was hemodynamically unstable, we immediately took the patient to cath lab and put a temporary pacemaker and with a bipolar mode. That's why the spikes are very small.
Oh.
And the rate was kept at between 70 and 80 beats per minute. This was the ECG on the next morning. Please give the poll.
This is Jamil bhai, this is reassuring because with the second EKG, I thought, did we miss the first one? so the pacemaker was a very reassuring thing for me. And also, I think you have given choices, but I think we'll have to accept that there is not only inferior, there is a posterior also.
Yeah, exactly, sir.
Yeah.
Troponin went up?
It was very high.
Yeah.
High sensitive troponin was more than 1,000.
Yeah. Do you use 4th generation or 5th generation troponin?
We use high sensitive troponin. Whether I don't know about the generation.
Okay, so yeah,
Jamil,
4th or 5th.
Jamil,
this the pacemaker was still in this patient when the ECG was done.
Yes, sir. Yes, sir.
So the pacemaker was not capturing.
Yeah,
right,
there was loss.
Okay.
So Jamil, there is no option in your, that is the answer, that is the capsule, that is the pacemaker related, but clinical there is a capsule failure of the pacemaker.
Yes, sir. And actually, the patient was in his own rhythm with some missing. And in that gap period, there was pacing spikes, but it failed to capture. After manipulating the catheter, it started pacing again.
Is the pattern in MBBS type 1? PR was variable a little bit.
Yeah. MBBS type 1, there was gradual prolongation also.
Yeah.
So one of the things you should be careful with this kind of patient, that somebody who had an inferior MI and failure to capture, when you pull the lead out, manipulate it, just make sure that you anticipate perforation.
Yes, sir.
And take necessary precautions so that it doesn't come as a surprise.
Sir. It was the this ECG was on the next day. We were preparing for procedure, and seeing this ECG, I opted. The party was briefed by our mid-level doctors for pacemaker, and after seeing this, I told them that he may not be requiring any pacemaker. Let's do the coronary angiogram first and treat the MI first. MI first. Then we did the angiogram. This was the left system, and there is retrograde filling of the RCA from left system. L6 was just whole artery was little irregular, but no critical block.
LAD mild disease.
But Jamil bhai, my question is, when you took for the temporary wear, why not angiogram that time? Because of the consent problem?
Consent problem, one, and at that time, the ER doctor and our mid-level doctor has failed to recognize the inferior MI in the first ECG. And it was in the evening time, most likely. I was out of hospital at that time. So they kept in that way. And the history is 3 days older.
But we are lucky because this patient presented with the Brady and then temporary wear. Sometimes you may end up in other directions that they may go into tachy and the VFib arrest.
Yes. This LAD had a critical lesion in the early, proximal and early mid segment. And this was the right coronary artery, totally occluded, proximal. So we wired the right coronary, did ballooning, and later we stented the lesion with the cerulemus eluting stent.
So Rafique bhai, what's your prediction? We may need or we can avoid the pacemaker altogether as we are doing the reperfusion?
Yeah, I will not put a pacemaker.
Late.
Yeah, I mean, this patient, even before reperfusion, conduction came back. So inferior MI, you wait at least 48 hours, if not longer, before you decide on a pacemaker. And this patient is not going to need a pacemaker.
And interestingly, in the cath lab, after establishing the perfusion of the right coronary, monitor was showing normal sinus rhythm. And then we stented the LAD also. The long stent covering the whole diseased area.
In the right coronary, have you done thrombectomy or just after balloon as a TB3 flow was there, the right coronary?
We didn't do any thrombus aspiration. just did ballooning and put a stent there.
Good result.
So it was the ECG just after the procedure. And he was in sinus rhythm with little prolongation of PR interval. And this was the ECG before the discharge. And his PR interval became normal. And the inferior MI is evident. And ST segment came down.
Yeah, excellent, sir.
So now I go for the second case. A 61 years old hypertensive non-diabetic lady presented to ER with chest pain and shortness of breath for 2 hours. This was the ECG recorded at ER. Please give the poll. So only one person is responding. Tushar. মামা আমি একটা মিটিং এ আছি, একটু পরে ফোন দিচ্ছি। Anyone like to discuss? Wadud?
Yeah, can I say something? I think this is
Sure.
highlighted with the reciprocal change in the free lead. So it looks like acute MI case rather than the pericarditis.
Yeah.
Rafique sir, are you listening? Rafique sir, are you there?
Yes.
Sir, as a trainee or as a junior doctor, many a times the reciprocal changes, the term and its implications gets a bit confusing. Can you make the thing clear for us?
This is for Hafiz to answer. Hafiz.
It requires ischemia.
Yeah, I will ask Hafiz to request Hafiz to answer that question. That's more of his field. Hafiz? Is Hafiz online?
This moment he is not online, sir.
I mean, reciprocal change we always see in ECGs. And it depends on the extent of ischemia. I mean, this is inferior, is kind of funny location. Like with a lot of times, with acute inferior MI, you see the reciprocal change in V1, V2, V3.
Yes, sir.
Yeah.
But some authority says that these reciprocal changes are actually myocardial ischemia.
Yeah, it may, because the issue is that if there is disease of the RCA also, and it will show up as inferior ischemia.
Yes.
So, did you do CAS on this question?
Yes, sir. Yes. So we opted for, we offered primary PCI as she came within 2 months, 2 hours, and they agreed. But at that time, the cath lab was busy. We had only one active cath lab at that time. Now we have 2 active cath labs. So we kept the patient in the CCO, and there another ECG was done, and the ST changes increased more. And now it also shows some ST elevation in V2 as well.
Yeah.
So we did cath. This was the right coronary artery. It's completely normal.
Circumflex must be the PDA.
So this was the left coronary. It's a distal left tapering and almost subtotal occlusion at the bifurcation. Neither LAD nor LCX getting full blood flow. So we wired the LAD and LCX both. And then we took a balloon 1.5 millimeter into 12 to dilate at the bifurcation at the ostium of the LAD first. And after first dilatation, the flow came back and LCX got reperfused automatically. And took another 2 millimeter balloon, 2 into 15 millimeter. So after that, flow improved more. And this is the, after second ballooning, the LAD flow was established. And then we stented the LAD. It was after stenting the LAD. The only thing is this one WM was got some clot and no flow. So we didn't maneuver there and just given bolus integralin. And the patient was shifted to CCO, and this was the post-procedural ECG. And the patient recovered nicely. She had some basal crepitation on the next day also, but later as she becomes stable and we could send her home safely, and she came for follow-up after 2 months, and she is doing fine, no further symptom.
Dr. Jamil, so what is the clinical condition of the patient during the angiogram when the patient was on the table? That is the during the angiogram.
She was stable at that time.
Yeah. Have you discussed with the surgeon because of this distal left maneuver and this one?
No, surgeon was at that time. Surgeon was busy with surgery. He was in the OT.
Interestingly, ECG, the AVR was not that much elevated we were expecting. So this coronary angiogram should give a ECG picture of positive AVR. It was not that time. Later, it may be a little bit high. Yeah, that's good.
Yeah.
Sir, could you have done some intervention in OM, which is a very large area?
That could be done, but to me, it seemed that it will take another more time. And she was, that WM actually was, the shifting clot went into the, from the ostial segment of the LAD, LCX. Then we have given 2 bolus intracoronary integralin and hope that that would disappear with time. Flow will get re-established. And she had no further complication or chest pain or any new changes in ECGs.
Yeah, I must say it is a great job. You have done that on the PCI, which is maybe most of the people will not go because of the many, at least MDT with surgery. Patient might collapse on that table. I must say it's a great job.
Thank you.
Sir, before moving on to the next case, I want to ask Rafique sir just another thing. Sir, many a times it is the teaching, many a times it's the teaching in the medicine world that without the reciprocal ST changes, uh, saying an ECG MI a bit difficult.
Not necessarily.
Without changes, reciprocal change, what was the question?
Sir, likewise, in this ECG, there is ST elevation in one AVL and ST depression in inferior limbs. Many a times, without that ST depression or reciprocal changes, some thoughts are there that it cannot be said acute ST elevation MI in the high lateral MI.
No, I don't think so. Because this case was very interesting because if you look at the extent of disease and the extent of ECG change, doesn't correlate that much. But
yes,
patient is severe, I mean, it's basically left main stenosis. And the other question was the surgery. This patient, no surgeon will accept this patient for surgery with that kind of condition. So I think it was fantastic job done on this patient.
Thank you, sir. I go for the third case. A 82 years old lady, hypertensive, non-diabetic, chronic kidney disease stage 3 and Parkinson's disease, presented with 3 days complaints of generalized weakness, loss of appetite, dizziness. On examination, her pulse was 32 beats per minute. BP was 80/40 millimeter mercury, an altered level of consciousness. This was the ECG recorded at ER. Please give the poll.
Hey, Corey.
See. Otherwise, anyone would like to comment?
I feel it's a junctional.
Okay. Tushar?
I'll say severe sinus bradycardia as the lead 2 shows positive P wave and the P and QRS relationship is still maintained. And with severe bradycardia, but P QRS relationship is maintained and the P in
this
lead
one
2.
is, you want to say this one is P wave?
Yes, sir.
If you correlate with the similar complex in lead 1, lead 3, this is the QRS complex that correspond with this wave in lead 2. And there is another small wave just after that complex.
Yes.
Yeah. Retrograde P wave is there. Looks like it's junctional.
If that is P wave, if we say that is Q, sorry, sir, yes. If that is QRS, if that is retrograde P wave, that is junctional.
It's junctional bradycardia.
I was taking that thing earlier. So if we compare with the lead 1, 3, then the initial positive complex is the QRS and the later on negative complex is the P wave, which goes in favor of junctional bradycardia.
Yeah, same it is seen in lead 4, 5, V4, V5. QRS followed by P wave, 5, 6. After admission in CCU, heartbeat improved to 52 beats per minute. BP also improved 100/60. Patient still drowsy and disoriented. As there was hemodynamic improvement, TPM was not done. This was the ECG in CCU. Now what is the diagnosis? Poll, please. B and C. Anyone like to explain?
Yeah, I feel still is junctional because I can't see the PP in the clear 221, no PR regular, no clear P wave in the after T wave. So it's still retrograde P and could be junctional.
Yes. Still
Yes, and AVR,
junctional rhythm.
in AVR, the positive P wave is seen clearly. After QRS, there is
After QRS, there is in AVR the P waves. In every
Yes,
lead, there is retrograde P wave just after the QRS complex. In the limb leads, lead 2,
Right.
AVR, lead 3. So it was still junctional rhythm. This was her electrolytes. Gross electrolyte imbalance, sodium and chloride reduced, and potassium raised up to 6.32. And this was the ECG on the next morning. Here, the sinus rhythm came back with little irregularity with the respiratory phases. At that time, potassium came down below 5, and sodium was above 120. And the patient improved, and we didn't go for further procedure. The fourth case and last case, a 60 years old diabetic smoker, non-hypertensive gentleman presented to ER with central chest pain associated with sweating for 1 hour. He was hemodynamically stable. This was the ECG recorded at ER. Please give the poll. A and C equal. So anyone want to comment?
Yeah, I believe it's entero-MI, RBPP pattern in a massive MI looks like. The other feature of pericarditis is not there. PR depression, PR elevation, no sporadic sign. It is regional in the anterior leads. So it looks like an entero-MI.
Could it be Prince metal as there is concavity up in this television?
Could be. How's the troponin maybe? But the ECG looks like. But we need to do an echo, and troponin will help us maybe in the bedside.
And this was the ECG taken just 23 minutes after later. While we were waiting for troponin, and it became almost normal just after 23 minutes. And when we received the patient was actually offered for primary PCI, and their guardian was causing delay, so we shifted the patient from ER to CCO, and this ECG was taken in CCO, and he became normalized. And at that time, the mid-level doctor rang me up that within 20 minutes, the ECG became normal. What should we do? Will you go for thrombolysis? Then I said, as it became, and they sent me both the ECGs in WhatsApp. I saw and said that as it became normalized, just keep him on low molecular weight heparin. Don't go for thrombolysis. And after 2 days, we went for CAT.
Yeah, this patient must have been procedure.
Yeah. His troponin was also more than 1,000 nanogram per liter. So we didn't go for primary PCI or thrombolysis. We did a pre-discharge angiogram, and it was like this. His right coronary was non-dominant, small, and this was the left system. Here is a little lesion is there, doubtful lesion, just in the proximal segment. And the L6 has also disease. Let me show it here. Here is also 50–60% lesion in the left circumflex, just after the principal vein. And then we offered the party for IFR guided PCI for both the lesion, but the patient party opted for going abroad. So we didn't do anything. The patient came for follow-up in my OPD after 1 week. He was doing fine, no symptom.
So Jamil, any history of any drug use?
Sir.
Any history of drug use?
No, sir.
Any history of drug?
No, sir. He's only a smoker. He came at that time while there was follow-up Awami League, and he is ward Awami League president. Not commissioner, he is Awami League ward president, and he was very tense at that time. All people were going after the people who were doing Awami League and attacking their home, and was beating. Some people were killed. So he was very tense. At that time, this happened to him.
Okay, so on discharge, what medication you have given? Because he refused their image guided or FAR guided PCR.
We gave him dual antiplatelet, nitrate, beta blocker also, and high dose statin, atorvastatin 40 milligram.
No diltiazem or something like this?
No.
Okay. So can I say something? Actually, this the troponin is high in the diabetic patient. So ideally, this patient should have been an image guided, either IVIS or OCT. because so many times we saw the people with, even coronary is no mild disease, but if you do the IVAS or OCT, you see the rupture plaque. Yeah.
We had
So,
IVAS. We offered them that IVAS and IFR, but they didn't want to do anything further.
Yeah,
so
recently I have done one cases, similar cases in the LAD. It was a mild disease, but troponins was very high. After OCT, it was a rupture plaque. So finally we end up with the PCI. Anyway, so he's lucky enough. He's doing fine with the medication.
Atahar sir, are you there?
Tushar, if you have time, I would like to show 3 ECGs.
Okay, sir.
Yes, sir.
Yes, sir.
Give me 1 second. I'm just getting this thing ready.
Sir. শেষে কনক্লুড করতে অন্য কাউকে দিও, না তাহলে খারাপ জায়গায় গেল। হ্যাঁ, অন্য কাউকে ডাকবো। আর স্যার ইসি দেখে এখানে।
And if anybody else wants to talk anything.
No, sir. Jamil,
স্যার হ্যাঁ তো ভাই,
না তোমার স্ক্রিন শেয়ার তো স্টপ করছে না? ওকে,
সব হচ্ছে না শেয়ার?
হ্যাঁ হ্যাঁ হ্যাঁ। Rafique sir.
Yeah.
Sir,
give me 1 second. Give me 1 second.
Yes, sir.
Okay, sir. Meanwhile, I'm asking Atahar sir. So if you find the ECG change like this, will you still offer the patient angiogram at that very instance, or you will wait for 1 or 2 days? The last ECG, normalization of ST elevation, but persistence TF inversion V1, V2.
No, actually there was MIS because the troponin was grossly raised as the patient has got the evidence of the MI. So classically the angiogram was indicated.
Yeah, I do agree.
Kind of an interesting case because vasospastic angina is very common in Japan. In Bangladesh, in US, it's not very common. So a good case. Okay. Let me see. I'm having little difficulty.
Sir, we are unable to see the videos or the.
Yeah, give me 1 second. Let me come to the screen. Okay. Share screen. Okay. Can you see it now?
Can you please? Okay. Yes, sir. We're seeing.
Sure. So this was actually an ECG I got from Chowdhury H. He's in Chittagong, right?
Yes. He's in Cox's Bazar. He was in Cox's Bazar.
So this ECG, and I have put the question. I would like as many people to answer as possible. Remember, your answer is important. It doesn't matter whether it is right, wrong. Don't worry about it. Just answer and we'll talk about it. Okay. Only first degree here. Okay, so we got anybody wants to discuss this ECG? Jamil or Tushar, Atahar?
Sir, if you look carefully, the lead V1, so the P waves are visible in the negative P waves are clearly visible, and the PR interval is variable, in fact. So, and the RBB is there. So, it is, to me, it's a complete heart block with RBB, the posterior fascicular block.
Okay. Anybody else? Any comment?
Yes, sir, I can make comments, sir. Actually, sir,
Yes, sure.
I can start with the option 4, that is the complete heart block. From the rhythm analysis, complete heart block, I want to exclude complete heart block as because the PR intervals are fixed. So complete heart block is excluded. But evidence of the old enteromyocardial infarction, I cannot straight away exclude this as because there is a that is the progression of the R wave is not that is in the usual fashion. Sir, number 3, complete heart block, RBB with late fascicular block. Sir, this is again excluded as because there is no evidence of the complete heart block. So there is a differentiation between the 1 and 2. The 2 is, I am in more favor of the 2, that is the sinus rhythm, first degree AV block, RBB, and late fascicular block. And because of this late fascicular block, the lead 1 and the lead 1 is negative, as well as AVL is negative. And the ECG changes in the precutal, it is also in favor of the fascicular block. So I am, that is a more in favor of the number 2 option, sir.
Jamil, any idea, any comment? Or is Jamil gone?
Sorry, sir, had to visit the washroom.
Sure.
Science. 1 minute, sir.
So this is everybody answered 1 and 2, except Tushar. What do you think? This is sent from by Chowdhury H from Cox's Bazar.
Sir, is there any chance of AV dissociation?
That's I'm waiting for your comment. We'll talk about it. But what do you think?
I think there is AV dissociation, and there is every alternate bit P and QRS merges.
Okay.
And
so
I
think we have all, yeah.
And the P between this complex, there is a single P wave only, non-conducting. And here another P wave, and it's falls on the QRS complex.
Yeah. Good. All right. So this is what I did. I expanded the initial part of the ECG in AVF. If you look at it suddenly, it looks like PQRS, so sinus rhythm with first degree AV block. But one thing is funny. If you look at the QRS, it looks kind of funny. It doesn't look uniform shape, the QRS. And then if I look at the end of it, here you can actually clearly see the dissociation. There is a P, 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 P. So end of the strip, there is clear AV dissociation. In the beginning, the QRS and the P merge, it looked like QRS complex. So it's a funny ECG And the rate is such that it is very easy to confuse a sinus rhythm with first degree AV block because it's not very slow. And the second question is, I also added here, I forgot to add the right bundle branch block. That is right bundle branch because there's a tall R wave. The question is there anterolateral myocardial infarction? Again, it's a little confusing because if you look at here, it looks RSR pattern. But if we move here in V1, there is a
QR patterns.
QR pattern. And
Yes.
then that QR pattern continues until V6. And because of the presence of this is the P wave actually, which made the initial RSR. So I think it's basically it's complete heart block with right bundle branch block, left posterior fascicular block, and old anterolateral myocardial infarction. It's a fantastic ECG. So the bottom line is that look at an ECG, and if something is not right, then you look more. If you suddenly looked at it and said, oh, this is first degree AV block, right bundle branch block, you can ignore, you can look at it that way, but then you think a little bit more, something is not looking right in the rhythm strip in the bottom. Something doesn't look like in the QRS complex, even though if you look at my pointer, the QRS looks kind of double notched, but it then changes pattern over here. It becomes single QRS. So that means there is something overlapping here. So this is the funny thing. That's the way I look at ECG. I look at ECG and I say, well, I don't know what it is, but it doesn't look right. And then you start analyzing.
Can I put my comment, sir?
Sure.
Govindo.
Govindo,
sir, when এই তো স্যার ভালো আছেন না? আচ্ছা, I would say the when complete heart block actual diagnosis, in that case, left posterior fascicular block, why in addition?
Okay, so the question is
complete heart block.
Absolutely right. So the complete heart block, the question is, where is the escape beat coming from? If the escape beat is coming from the ventricle, you will not mention that at all. But this case, it probably is a junctional escape beat, and that matches with the rate. So that if there is a junctional escape with complete heart block, you will follow the old pattern of bundle branch block, and that's what it is. Yeah, you are absolutely right. Normally, you don't deal with that. But this is probably one of those cases where patient had underlying right bundle branch block, left posterior fascicular block pre-existing, and with a junctional escape rhythm.
Sir, can I
another thing, sir, there is a reverse progression of R wave. Sir, you mentioned the old anterolateral MI, but there is a small teeny R wave in that. Is there any echo findings in this particular patient, sir?
No, I don't have echo. You are right. Initially, if you look at lead V1 and V2, it looks like an R wave. Actually, this is the P wave. If you look at this complex, there is no such R wave.
Yeah.
So that's why I added the anterolateral.
Thank you, sir.
So what was the symptom of the patient, sir?
I don't know. Chowdhury Sahib just sent me that ECG. He posted it on the Facebook. And then I asked him to get this ECG. And I thought it will be a good, interesting discussion of this. I don't know what are the symptoms.
Definitely disease is very difficult, sir. But on the other way, if patient has a syncope like this one, it could be a trifascicular block in the form of what other people are saying. Okay, so even in that case, the patient maybe will end up with the pacemaker. So anyway, it's a very interesting ECG.
Sure. No, I'm sure this patient had trifascicular block to start with, because had right bundle left posterior and most probably had baseline first degree and then progressed into complete heart block.
Right. Yes, sir.
But ventricular rate here around 60-65. So why the chance of having the syncope, pre-syncope, even in complete heart block?
No, we don't know that. I don't know what the symptom was, but this kind of patient can have intermittent. Let's say patient goes into heart block. Initially, they can have a pause, and then the junction takes over.
Right.
And that's when people, we have seen many patients with complete heart block who comes with syncope, and when they present to the the first ECG in the ER showed heart rate of 40. How did they have the syncope? It is possible that when they first went into heart block, there was a pause of 3, 4, 5 seconds. They passed out, and then the junction or ventricle took over. And this is probably can happen in this kind
Reflex. Reflex.
Thank you, sir.
Again, sir, new onset AV dissociation, even the rate above 60 ventricular rate, it's not reliable. It anytime it may go down.
Oh, yes, definitely. Definitely.
True. Yeah.
All right. Thank you.
Thank you, sir.
Rafique sir, do you have any other ECGs?
No, that's just this one. Thank you.
Okay. Thank you very much.
Tushar.
Sure.
Tushar. আচ্ছা এরপরে সাবসিকুয়েন্ট প্রেজেন্টেশনের জন্য তুষার
প্লিজ।
হ্যাঁ আমি বলতে চাচ্ছি যে আমি বলতে চাচ্ছি একটা কল আসছিল, আমি বলতে চাচ্ছি যে সাবসিকুয়েন্ট যে এইগুলোতে পরপর যে রবিবার যে করবে 2টা বা 3টা, এটাতে কি সেট হয়ে গিয়েছে? প্রেজেন্টেশন কে করবে এটা একটু জাস্ট জানতে চাচ্ছিলাম আর কি।
গোবিন্দ, আগামী 13 তারিখে প্রেজেন্টেশন আছে, হয় রফিক স্যার অথবা আজিজ ভাই করবে। তুমি কি করতে চাচ্ছ এর মাঝখানে?
13 তারিখ, দ্যাট মিনস আজকে তো হলো স্যার তারিখ, আমি ঢাকা থেকে ফিরতেছি, আজকে তো 22 তারিখ, 13ই অক্টোবর। 13ই অক্টোবর
তুমি তার
13ই অক্টোবর করুক, পরেরটাতে করি স্যার।
হ্যাঁ ঠিক আছে, তাহলে
মানে 20 তারিখ
ফিক্স করো। হ্যাঁ
জি স্যার, আমার মোটামুটি রেডি আছে, তাহলে আমি একটু করতে চাচ্ছি আর কি স্যার। ঠিক আছে স্যার।
13 আর কত হবে? 27।
13 আর 27 স্যার।
ও 15 দিন পর তো না, 15 ফোর্টনাইটলি। ও আচ্ছা ঠিক আছে, তাহলে অসুবিধা হবে না।
ওকে, কথা হবে তাহলে। বাই, খোদা হাফেজ।
Thank you, sir.
Thank you, sir.
Before conclusion, I'd like to hear from you regarding the presentation and requesting you to conclude the session. Rafique sir.
Thank you all for participating. I mean, Jamil, it's an excellent presentation. 2 things it's showing. One, of course, the ECG, the clinical scenario. Second, the interventions that were done. Excellent. And of course, as usual, Jamil is a fantastic teacher. Thank you all for joining.
Thank you, sir.
Thank you, sir.
Thank you, Jamil.
Thank you, sir.
Thank you.
Conclude করুন।